Today I'm starting Andreas profile. Andreas profile out of all the files, I mean, not profile, I'm sorry, Andreas file. Out of all the files that I have seen, it seems like Andreas file has the most complete material along with the most accurate answers that I have seen. So we're gonna review interest file and try to memorize as much as we can and try to remember as much as we can of interest file. So endodontics, we are going to start with endodontics, and the first portion uh, the first portion of interest file endodontics is the diagnosis. We're gonna do a review on the diagnosis of endodontics, and then we'll go into pulp diagnostic, and then periodicular or periapical conditions. Uh, then we will see some endodontic treatment information. Then we will see some primary tonsillectomy. We'll see root canal medications and irrigation. We're going to see a false teeth, splints, endodontic lesions, failure of root canal therapies, and access of root canal therapies. Okay, so endodontics on Andreas file. The diagnosis, precaution. Precaution, positive to precaution, it means that there's a presence of inflammation in the periodontal ligament or not. Depending on the results of the precaution, you will see that there's a presence of inflammation on the periodontal ligament or if there is not. This is all in the subject of diagnostics. Palpation. Palpation is the spread, not the spread, but palpation, um, you will determine whether the inflammation has spread to periodontum from the periodontium, from the periodontal ligament or not. Um,
Paradonium.
Periodontium from the periodontal ligament or not. When you have a periodontal problem, pain to lateral percussion on a tooth with wide sulcular pocket. Pulp vitality,
Vitality.
pulp vitality, necrosis or not. Example, how do you distinguish acute apical abscess and periodontal abscess? Vitality. How do you distinguish, this is an example of a question, how do you distinguish acute apical abscess and a periodontal abscess? Vitality. The thermal test is the second exam. You have exams of diagnostics. We have percussion, we have palpation, pulp vitality. Now the fourth one is thermal test, hot or cold. Pulp vitality, always the thermal test for to test the pulp vitality is always the most reliable. Um, if you have hot uh, sensitivity to hot, you are seeing irreversible, and if you're seeing cold, it's reversible. Next, transillumination. Transillumination is used to seek cracked tooth. Endoperio, pulpal necrosis leading to a perio problem as pus drains from the periodontal ligament. Endoperio, pulpal necrosis leading to a perio problem as pus drains from periodontal ligament. A perioendo, infection from the pocket that spreads to the pulp causing pulpal necrosis. To differentiate between endoperiolesion lesion, you do electrical pulp tests, and precaution will help you determine, differentiate between the two. So, second point, pulp necrosis. A normal pulp is symptom free and will normally be responsive to an electric pulp tester. When evaluated by thermal testing, the normal pulp produces a positive response that is mild and subsides immediately when the stimulus is removed. Slight pain of 1 to 2 seconds. Now, an reversible pulpitis. Reversible pulpitis is a clinical diagnostic indicating that the inflammation should resolve and pulp return to normal. The patient's chief complaint is usually of an exaggerated response to thermal stimuli, but once the stimuli is removed, the discomfort does not linger. Electrical pulp test results are responsive, strong, momentary, and painful responses. Again, the patient's chief complaint is usually of an exaggerated response to thermal stimulus. But once the stimulus is removed, the discomfort does not linger. Electrical pulp tests result electrical pulp test results are responsive, strong, momentary, and painful responses. This is for a reversible pulpitis. Now, a symptomatic irreversible pulpitis. If the inflammatory process progresses, irreversible pulpitis can develop. Patients may have a history of spontaneous pain and complain of an exaggerated response to hot or cold that lingers after the stimuli is removed. Removal of the cold causes return of symptoms and can be used as a diagnosis. Moderate to painful response and is positive to heat. Symptomatic irreversible pulpitis. Again, um, exaggerated response to hot and cold that lingers after a stimuli is removed. Now, asymptomatic irreversible pulpitis, clinical diagnostic indicating that vital inflamed pulp is incapable of healing. No clinical symptoms but inflammation produced by caries excavation, and trauma. Pulpal necrosis. Necrosis is a histologic term that denotes death of the pulp. Discolored tooth, unstimulated night pain, teeth with total pulpal necrosis are usually asymptomatic unless inflammation has progressed to the periorbicular tissues. The pulp will not respond to electrical pulp tests, and if using a digital electrical pulp test, this result should be reported as no responsive, NR over 80. The pulp will not respond to thermal tests in a pulpal necrosis. The dental record entry for this pulpal necrosis, for this pulpal diagnosis should be pulpal necrosis. The polymorphonuclear cells in necrotic pulp. Yes to palpation, yes to precaution. No, not polymorphonuclear cells in necrotic pulp. I meant to say, polymorphonuclear cells in necrotic pulp. So remember that polymorphonuclear cells are granulocytes, and these are white blood cells that are characterized by all the granules in their plasma, and they are also called polymorphonuclear leukocytes or polymorphonuclear neutrophils because they are have varying shapes of the nucleus, which is usually locked into three segments. So, pulpless tooth. The next one in the pulp diagnosis is a pulpless tooth, a tooth from which the pulp has been removed. For example, a tooth with previous pulpotomy, pulpectomy, root canal debridement, or previous root canal therapy should be recorded as a pulpless tooth for a pulpal diagnosis. Previously treated, a clinical diagnostic category indicating that the tooth has been endodontically treated and the canals are obturated with various filling materials other than intercanal medicaments. Previously initiated therapy, a clinical diagnosis category indicating that the tooth has been previously treated by partial endodontic therapy like pulpotomy or pulpectomy. A previously treated, it's a tooth that has been endodontically treated and the canals are obturated with various fillings materials other than intracranial, intracanal medications. For example, a normal pulp, there's two tables. Pulpal diagnosis, it's normal pulp, reversible pulpitis, symptomatic irreversible pulpitis, and pulp necrosis. Okay, in a normal pulp, the cold response is not delayed it's not delayed and it has very short linger. No treatment necessary. In a reversible pulpitis, the cold response lingers less than 10 to 15 seconds, and the treatment is remove the causative agent. In a symptomatic irreversible pulpitis, the cold response lingers longer than 15 seconds, and the root canal therapy or extraction are the treatments. And on the last one, pulp necrosis, there is no response, and of course, the treatment indicated is also root canal therapy. So now this next table talks about pulpal diagnosis based on thermal testing. So a pulpal diagnosis of a normal pulp will have a response to thermal testing that is going to be mild to moderate pain, lasting 1 to 2 seconds after removal of stimulus. That's a normal pulp. In reversible pulpitis, there will be severe momentary pain lasting 1 to 2 seconds after removal of stimulus. In irreversible pulpitis, there will be moderate to severe pain that lingers. And in a necrotic, there will be no response at all. So next point, periradicular and periapical conditions. Normal periradicular tissues. These tissues that are normal will be non-sensitive to percussion and paddle testing. Palpation, I'm sorry. Normal periradicular tissues will be non-sensitive to percussion and palpation testing. Radiographically, periradicular tissues are normal with an intact lamina dura and a uniform periodontal ligament space. Again, radiographically, periradicular tissues are normal with an intact lamina dura and a uniform periodontal ligament space. Next is an acute periradicular periodontitis or symptomatic apical periodontitis. Again, acute periradicular periodontitis or symptomatic apical periodontitis. This apical periradicular periodontitis, no, acute periradicular periodontitis occurs when the pulpal disease extends into the surrounding periodicular tissues and causes inflammation. However, acute periodicular periodontitis may also occur as a result of occlusal trauma. The patient will generally complain of discomfort to biting or chewing. Sensitivity to percussion and palpation is a hallmark diagnostic test on an acute periodicular periodontitis. The periodontal ligament space may appear normal, widened, or there may or may not have apical radiolucency. Next, chronic periodicular periodontitis or asymptomatic apical periodontitis. When bacteria or bacterial products from a necrotic pulp or pulpless tooth slow ingress into a periodicular tissue, the patient's immune system may become involved in a chronic conflict. The resultant inflammatory process causes periodicular bone resorption and destruction that manifests as a periodicular radiolucency on the radiograph. Clinically, the patient is asymptomatic. Percussion and palpation testing produce non-sensitive responses. Now, acute periodicular abscess. Acute periodicular abscess. In this situation, bacteria has progressed into the periodicular tissues, and the patient's immune response cannot defend against the invasion. It is a characterized by rapid onset, spontaneous pain, pus formation, and often swelling of the associated tissues. Depending upon the location of the apices of the tooth and muscle attachments, a swelling will usually develop in the buccal vestibule, on the lingual, palatal, or as a facial space infection. Percussion testing produces a response that is usually exquisitely sensitive. This exaggerated response can help differentiate between acute periodicular periodontitis and the early stages of acute periodicular abscess. Palpation testing produces a sensitive response. Radiographically, the periodontal ligament space may be normal, slightly widened, and demonstrate a distinct radiolucency. Sinus tract is a hallmark. You must drain the lesion. So again, depending upon the location of the apices of the tooth and muscle attachments, a swelling will usually develop on the buccal vestibule. It is an acute periodicular abscess is characterized by rapid onset, spontaneous pain, pus formation, and often swelling of the associated tissues. Now we have a subacute periodicular periodontitis. The patient will present with mild to moderate symptoms that may include spontaneous pain or discomfort from biting and chewing. The tooth may present with any pulpal diagnosis. Percussion testing produces a mild sedative response, and palpation testing may or may not be sensitive. Again, the tooth may present with any pulpal diagnosis. Percussion testing produces a mild sedative response, and palpation testing may or may not be sensitive. This is a subacute periodicular periodontitis. The patient will present with mild to moderate symptoms that may include spontaneous pain or discomfort on biting and chewing. The tooth may present with a pulpal diagnosis. Percussion testing produces a mild sensitive response, and palpation testing may or may not be sensitive. Clinical symptoms are not as severe as an acute periodicular periodontitis. Radiographically, the tooth will present anywhere from a normal periodicular appearance to a distinct radiolucency. These patients must receive endodontic treatment receive periodontal treatment. Not periodontal. Periodic. Again. These patients must receive endodontic treatment in a timely manner because the condition can quickly progress into acute periodicular periodontitis or an acute periodicular abscess. Now, a chronic periodicular or apical abscess is the next thing. Let me take. So, chronic periodicular or apical abscess, an inflammatory reaction to pulpal infections and necrosis, characterized by gradual onset, little or no discomfort, and intermittent discharge of pus through an associated sinus tract. Clinically, the patient is usually asymptomatic because the sinus tract allows drainage of any exudate from the periodicular tissue, intermittent discharge of pus. The EPT, the electrical pulse test, and thermal testing are non-responsive. Percussion and palpation testing are usually produce non-sensitive responses. Radiographically, aperiodic if there is granulomas persists. Focal sclerosing osteomyelitis, which is a condensing osteitis. This entity may be considered a true lesion of endodontic origin. The involved tooth will have an etiologic factor for low-grade chronic inflammation such as a necrotic pulp, extensive restorative history of a crack. The patient may be asymptomatic or demonstrate a wide range of pulpal symptoms. Again, the involved tooth will have an etiologic factor for low-grade chronic inflammation, such as necrotic pulp, extensive restorative history, or a crack. The patient may be asymptomatic or demonstrate a wide range of pulpal symptoms. Electrical pulp tests and thermal tests may or may not be responsive. Percussion and palpation testing may or may not be sensitive. Radiographically, the involved tooth will present with increased radio density and opacity around one of the or more of the roots, evidence supporting consideration of a lesion of odontogenic origin is that 85% of these periodicular radial densities resolve after endodontic therapy if they have a pulpal diagnosis of irreversible pulpitis. Next, focal osteopetrosis. This entity is not a lesion of endodontic origin. The patient will be asymptomatic. The electrical pulp tests and the thermal testings are responsive and normal. Percussion and palpation testing will typically be non-sensitive. The involved tooth is usually a virgin tooth or has a normal pulp. Radiographically, the tooth will present with increased radio density and opacity around one or more of the roots. No treatment necessary, and the tooth should be simply monitored at periodic recall. The electrical pulp test, the image 179 shows vital and 80 or over shows necrotic. Let's see, I-79, image 79. No, well, I don't know where we were, so. Worst prognosis, lesion, perio, endo. Best prognosis, lesions, endo, perio. Why? Because once you remove the endo uh, cause the agent that is causing the perio problem, that is okay. If the endo is causing the perio problem, you just fix the endo and the perio problem takes care of itself. But if you do it backwards, it's uh, you have to do perio treatment and then endo. So best prognosis is a lesion that is endoperio. Okay, so now we are all the way in perio treatment. We have seen so far diagnostics, we've seen pulp diagnostics, we have seen periodicular or periapical conditions, and now it's time to see endodontic treatment. Uh, endo root canal therapy first, endo um, SRP second. So pulpotomy. A pulpotomy is a removal of the coronal portion of the pulp. Carries more than 2/3 in the dentin. If the carious deciduous teeth, or for it is for carious deciduous teeth or for permanent teeth, undeveloped roots with undeveloped roots, like open apexes. It is an alternative to extraction when root canal therapy is not possible. Okay, so you should do a root canal therapy, but if you cannot, at least do um, the pulpotomy. Carries more than 2/3 indented. So it is an alternative to extraction when root canal therapy is not possible. Emergency 2, permanent teeth are not successful. I mean, even permanent teeth with acute pulpitis, you can do that as an emergency. Um, in permanent teeth with acute pulpitis. A pulpotomy in fully developed permanent teeth are not successful. It is just a temporary procedure. Okay, you use formocresol at 90 to 98% and then calcium hydroxide at 60%. That's the success rate. Formocresol 90 to 98, calcium hydroxide 60% success rate. Now, a pulpectomy, when irreversible pulpitis, you can do pulpectomy. When there's pulpal necrosis, hyperemic pulp, evidence of furcation, or PA involvement seen on the x-ray, spontaneous pain, buccal or extraoral swelling, and increased mobility, you can do pulpectomy. Next is pulp capping. Accidental pulp exposure mechanically, okay? Pulp of a young child, not in primary teeth with carious exposure. In primary, we do pulpotomy. So pulp capping is only accidental pulp exposure mechanically in a pulp of a young child. You will not do this in primary teeth with carious exposures, okay? Next is direct pulp capping. Place a sedative antiseptic on exposed healthy pulp. You can do dicol, just calcium hydroxide, pit, pinpoint, pinpoint. You can use it in a pinpoint um, exposed pulp. This is the direct pulp capping. Now, an indirect pulp capping, you remove the infected dentin and you place a liner of calcium hydroxide, 0.5 to 0.75 millimeters. Then uh, glass ionomer cement as a base. For deep carious lesions, you can do this. This is indicated in deep carious lesions with no chronic pain and um, no evidence of pathology in the x-ray. Vital pulps, normal tooth color,